If you look at these pictures, you can see that the nasal septum is simply just deviated. It isn't straight, it veers to the side. Symptoms will depend on how bad the deviation is. On the deviated side, the patient can experience congestion or difficulty clearing mucus. Mucus is supposed to trap bacteria before it exits the body, but if there is a buildup of mucus, the patient isn't getting rid of that bacteria, and that puts them at risk for frequent sinus infections. Patients who are asymptomatic or who have minor symptoms don't necessarily need surgery. If the deviation is severe, surgery can be done to realign the septum. A nasofracture is simply a broken nose. What you need to know is when to worry. We worry if the patient has persistent clear or pink tinged drainage because there's a possibility that this could be cerebrospinal fluid. Bruising around the eyes is concerning because there is a potential for it to be a basilar skull fracture. And we worry for any bleeding longer than 15 minutes because we worry about your patient losing too much blood or the bleed not stopping. Your goals for treatment will be to maintain a patent airway and reduce any swelling or discomfort that the patient may be experiencing. Now that we know the goals, we can focus on how to treat and why. First up, there is a note to give Tylenol instead of NSAIDs. The reason we would want to give Tylenol instead of NSAIDs is because NSAIDs increase the risk for bleeding. Since we are already worried about stopping the bleed with a nasofracture, we don't want to give NSAIDs when they could increase the bleeding. Tylenol can address the pain without increasing the risk for bleeding. We would give a nasal decongestant if the patient is experiencing any sort of congestion from swelling or trauma. We treat with saline nasal spray and humidifiers because we want to keep the nasal cavity moist. Any dryness can increase the pain and possibly increase the bleeding. Then, depending on how bad the fracture is, the patient may require surgery. When teaching the patient about what to avoid, we want to teach them to avoid hot showers because hot showers can vasodilate the vessels in the nasal area, which will increase the blood flow to that area, which could increase the bleeding. Teach to avoid alcohol because alcohol causes inflammation for this patient. We want to reduce inflammation. Lastly, we want to teach the patient to avoid smoking because smoking is very irritating to the mucous membranes. We don't want to cause any more irritation to that area. Rhinoplasty is just the fancy term for surgical reconstruction of the nose. So this patient is just having a nose surgery. After the nasal surgery, the patient will get nasal packing. This nasal packing is inserted after surgery to put pressure on the area and stop or prevent bleeding. Your patient will usually have this packing for 1 to 2 days. Your patient will also have an external plastic splint to protect and support the shape of the nose during the healing process, which is usually about 1 to 2 weeks. Everything that we teach this patient is about preventing bleeding, preventing injury, preventing swelling, and preventing pain. So why do we think it's good to teach about the use of cold compresses and elevation? Well, both of these are going to help prevent swelling. We want to teach the patient not to blow their nose because that will increase the pressure there, and that can restart the bleeding. You want to teach the patient to avoid swimming because of the nasal packing that is in place. And lastly, teach the patient to avoid strenuous exercise and heavy lifting because that will increase pressure and increase the risk for bleeding. Epistaxis is just a fancy word for nose bleeding. The patient can either have an anterior nosebleed or a posterior nosebleed. An anterior bleed is usually less severe and can usually be treated at home because the bleeding will stop spontaneously or with a little bit of pressure. For example, the bleeding will stop after the patient squeezes their nostrils for a few minutes. A posterior bleed is a little more worrisome and is more likely to require medical attention. These posterior bleeds are common in older adults with other problems like hypertension. So why do we think hypertension is a cause? Well, that is because with hypertension, we have more pressure inside of those vessels. With that higher pressure, the vessels are more likely to rupture and cause a bleed. The posterior bleeds will sometimes require packing, cauterization, or even a balloon catheter to apply pressure to the spot to stop the bleed. For treatment and education, we want to have the patient sit up and lean slightly forward, and we want to squeeze their nostrils to apply pressure to help stop the bleed. If you are doing home teaching about this, you want to teach your patient to seek medical attention if the bleed lasts longer than 15 minutes. You also want to teach the patient to use nasal saline sprays and humidifiers to keep the mucous membrane moist. This will prevent irritation and further bleeding. Teach the patient to avoid blowing their nose, sneezing through their nose, straining, or doing any strenuous activities because all of this will increase the pressure and increase the risk of bleeding further. Teach the patient to avoid NSAIDs because with NSAIDs there is a risk for bleeding. Antibiotic use is possible with trauma and if the healthcare provider thinks there is a risk for infection. Allergic rhinitis is inflammation of the nasal mucosa, and this is usually in response to an allergen. So before we talk about the symptoms, I want to talk about how we get these symptoms. When the body is exposed to an allergen, the body produces immunoglobulin E. We're going to call this IgE. IgE releases histamine and leukotrienes. Histamines cause inflammation. Leukotrienes cause tightening of airway muscles and produce excess mucus and fluid. So now that we know that the end result is inflammation, tightening of the airway, and excess mucus and fluid production, the symptoms make sense. The symptoms are sneezing, watery, itchy eyes and nose, congestion, sinus pressure, and runny nose. So how do we treat this for this patient? First and foremost, we want to identify the triggers and have the patient try their best to avoid the triggers. Antihistamines can help because antihistamines will treat the inflammation. An anticholinergic nasal spray will help this patient because it will reduce nasal secretions by blocking cholinergic receptors. Corticosteroid nasal sprays will help this patient by stopping the inflammatory response. We know that steroids help with inflammation, which is a problem here. Decongestants can help this patient with inflammation that they experience because of congestion. Lastly, we have immunotherapy, which is also known as an allergy shot. We use these allergy shots for a very specific, unavoidable allergen that is not responding to drug therapy. So what happens is a small amount of the allergen is injected weekly to decrease the patient's sensitivity to that allergen. Allergic rhinitis can be classified by either the frequency of symptoms or the causative agent. So if we look at the frequency of symptoms, we have episodic, intermittent, and persistent. With episodic, the patient is not experiencing the allergen every day in their normal environment. So an example here would be that the patient is allergic to dogs and they don't have a dog, but they visit their friend occasionally and their friend has a dog in the house. For intermittent frequency, the patient experiences the symptoms for less than 4 days a week or less than 4 weeks per year. With persistent, the patient experiences symptoms for more than 4 days per week or more than 4 weeks per year. If we classify by the causative agent, there is a seasonal classification or a perennial classification. A seasonal cause would be something like a pollen allergy that usually happens in the fall or the spring. A perennial classification would be something that happens year-round. An example of this would be that the patient is allergic to pet dander or dogs and they have a dog that lives inside their own house. Acute viral rhinopharyngitis is the fancy term for the common cold. This is an upper respiratory tract infection that is contagious through droplet spread. They can survive on objects for up to 3 days. Patients will usually start having symptoms 2 to 3 days after they are infected, and patients are contagious for 1 to 2 days before their symptoms even start. Symptoms for the common cold are a runny nose, congestion, sneezing, cough, sore throat, fatigue, headache, and fever. To treat the common cold, we will advise the patient to get some rest because their body is working hard to fight off an infection. We will teach the patient to stay hydrated. Staying hydrated will help to keep the mucus thin, which is easier for them to expel or cough up. Antihistamines will help with any inflammation they are experiencing or any congestion. Decongestants can help this patient with any congestion that they are experiencing, and cough suppressants will help with any cough that the patient may have. So something to note about cough suppressant use is that we don't want to suppress the patient's cough if they are coughing up mucus, because we want the patient to cough up that mucus and whatever it is that is making them sick. However, if your patient has a dry cough that is maybe just irritating and keeping them from sleeping at night, they absolutely could benefit from a cough suppressant. The question here is, during discharge instructions, a patient questions why they weren't prescribed antibiotics for a cold. How should the nurse respond? This is when the nurse would do teaching about when antibiotics are needed and teach that antibiotics only work for bacterial infections, not viral infections, and that colds are caused by a virus, so antibiotics would not help to treat the cold. This is also when the nurse could talk about antibiotic resistance when we overuse or unnecessarily use antibiotics. This question states that a nurse is caring for a patient with a productive wet cough. Why should the nurse question the 9 a.m. order for a PO cough suppressant? So we talked about this. We do not want to give a cough suppressant to a patient who is coughing up mucus. We want that patient to continue to cough up that mucus so we don't have additional problems. Influenza, or flu, is a highly contagious respiratory virus that is spread through droplets. Flu season is between the months of September and April, and we do have a yearly flu vaccine. A common misconception about the flu shot is that the flu shot can give you the flu. Because of this, it is important for nurses to educate patients and teach them that you cannot get the flu from the flu vaccine. However, it does take about 2 weeks for the flu vaccine to be fully effective and for the body to build up immunity. So sometimes we do have patients that will get the flu shortly after getting the flu vaccine. So they may think that they got the flu from the vaccine, but in reality, their body just didn't have enough time to build up immunity. The flu is transmissible 1 day before symptoms start and 7 days after the start of symptoms. The flu and a cold often have very similar symptoms, so we need to know what to look for to decipher between the two. With the flu, the onset of symptoms is more abrupt. It's quicker. Also, fever, especially a high fever, is more common with the flu, as well as body aches are also more common with the flu. A diagnostic that can be done to help decipher this is a viral culture. So that's how you'll hear about patients getting tested for the flu. To treat the flu, educate the patient to rest because the body is working hard to fight off a virus. Also, educate the patient to stay hydrated to help thin their mucus and make that mucus easier to cough up. We can teach the patient to take antipyretics when they have a fever. We can have the patient take analgesics for body aches. And we can educate our patients about antivirals. Antivirals will only be helpful for the flu if they are started within the first 48 hours of symptom onset. You have a list of medications on this slide that are considered antivirals, and if you look at their names, they do have a common ending. So you can see that common ending of VIR. A nurse is caring for an elderly patient diagnosed with the flu. What common secondary infection is the patient at risk for? What risk factors does this patient have? When thinking about the answer to this question, let's first think about our patient So we have an elderly patient with the flu, so they're probably not feeling well, and they're probably spending a lot of time in bed. Since they have the flu, we know they're probably experiencing a lot of mucus buildup, and with mucus buildup, we know that this is a very good environment for bacteria or viruses or even fungus to grow. If a patient is spending more time in bed and is not up and moving around, they are probably not expanding their lungs as well as they normally would. We also know with an elderly patient, their cough reflex typically isn't as strong as what we would like it to be. So when you combine all of these things together, such as laying in bed, not expanding their lungs well, not taking deep breaths, not having a strong cough reflex, having a buildup of mucus that has a buildup of particles in it, we know that this patient is at risk for that mucus with whatever particles are in it to get stuck at the bottom of their lungs, and this can easily become pneumonia. So here we have pneumonia. That would be our common secondary infection and that the patient is at risk for. And then everything that we just talked about is what puts this patient at risk for the pneumonia. Sinusitis is sinus inflammation that causes mucus to accumulate. Causes could be polyps, a deviated septum, allergies, foreign body, or anything that leads to inflammation that causes mucus to accumulate. Having this excess mucus sitting in your patient's sinus cavities creates an ideal environment for viruses, bacteria, and fungus. We know that viruses, bacteria, and fungus all thrive in warm, dark, moist environment. Mucus trapped in the sinus cavities creates the perfect environment for these things to grow. If your patient has viral sinusitis, no treatment is needed. It's a virus, so it will just run its course. With bacterial sinusitis, antibiotics are helpful because it is a bacteria. With a fungal sinusitis, we will give antifungals. However, this is the most uncommon type of sinusitis. Additionally, for treatment, we want to treat the symptoms. So if your patient is experiencing congestion, it makes sense that we would want to give a decongestant. We know that this patient will experience some inflammation, which is leading to the buildup of mucus, so it makes sense that we would want to give a nasal corticosteroid because we know steroids help treat inflammation. And analgesics are helpful for any pain associated with the inflammation. Nasal polyps are just growths inside the nasal cavity. These are soft, they don't cause any pain, and they are benign. These occur from repeated nasal inflammation. So, is it possible for someone with allergic rhinitis or repeated sinusitis to experience this? Absolutely. Patients with nasal polyps will experience some level of nasal obstruction. So they may say that they have some difficulty breathing through one or both of their nostrils, and they may experience some nasal discharge from the inflammation and irritation. A foreign body is just something that has entered the patient's nose that is not supposed to be there. Symptoms include pain, difficulty breathing, and nasal bleeding. This can be treated by trying to have the patient sneeze out the object. The patient can also try to include the unaffected nostril and blow forcefully out of the other nostril that has the object in it to try to force the object out. If these methods are unsuccessful, the patient would need to be instructed to contact their healthcare provider.